Roslani and Prof Hanafia and the College of Surgeons, Academy of Malaysia, has got us a very good deal that if you join the ISS, the membership fee is going to be 50% of the total fee, which is going to be quite a good discount. And 1st November, they're going to start the website. So on the website, if you register, if you join ISS, there's a drop-down list. You just look at CSAMM. It is one of the affiliated societies where your registration fees will be 50%. Thank you very much. That's the advertisement. Now I will start my topic. Options of neoadjuvant systemic therapies. From this, I'm going to be talking about what sort of neoadjuvant therapy there are. And there are the benefits of neoadjuvant systemic therapy. We know all this, isn't it? Initially, last time, maybe 20 years ago, we gave neoadjuvant systemic therapy to make an inoperable tumor operable. This was what we practiced long ago. Later on, when they have operable breast cancer, if the lump is large, we give neoadjuvant systemic therapy to downsize it so that we can do breast conserving surgery. And nowadays, we are giving neoadjuvant chemotherapy as a sort of test to see whether the cancer is sensitive to the systemic therapy or not. So you will find that it's prognostic. If pathological complete response is achieved, then the outcome will be better. If there's residual tumor cancer after neoadjuvant chemotherapy, the oncologist will now give you further systemic therapy, like in triple-negative breast cancer. If you don't get a complete pathological response, they will give capecitabine for 6 months after. And if it's residual disease after neoadjuvant chemo and Herceptin and Perjeta, I'm in private practice now, you can see this is the sort of treatment that we're giving, very expensive treatment, but somehow the patients can afford it. So if you do not get a complete pathological response after chemo, Herceptin and Perjeta, now what the oncologists do is they give Capsila, which is even more expensive than Herceptin and Perjeta. So it's very expensive, but all this is to give you a better outcome. And also you downstage them from positive disease to lymph node negative disease. So before neoadjuvant systemic therapy, diagnostic and staging workup is important. Determine if neoadjuvant systemic therapy is indicated. This needs a multidisciplinary team actually, because the patient sees the surgeon first. The surgeon makes the decision. Most times the surgeon makes the decision without consulting the oncologist, because we don't have time to call the oncologist, isn't it? And most of us, if it's operable, we just operate direct. If the patient wants a mastectomy, then you don't need to downsize it, then you can just do a mastectomy. So counseling of patient is important. And we also talk about ER/PR HER2, He67. ER/PR HER2 is essential. He67 is beneficial but not essential. I just came back from San Antonio, San Francisco, where I attended a session also on neoadjuvant therapy, where they said all patients, they do Oncotype DX before neoadjuvant systemic therapy. But that's in the US of A. So these are the types of breast cancer that Prof. Omar has spoken about. And the high-risk ones are the HER2 overexpressing and the triple-negative breast cancer. And the oncologist in my hospital, Dr. Mastura, says all patients with HER2 positive expressing and triple-negative, even if they are, as long as they are more than 1 cm, stage 1, they should have neoadjuvant systemic therapy. Okay? Now, what are the percentages of these 4 types? These are 2 studies done in UMMC, one done in Kuching by Dr. Mina. And you find that triple negative is very common in the indigenous group here. Almost 30% of the indigenous groups here are triple negative. Of course, the commonest type is the good type, which is the positive negative type. Okay? Oops. So, sorry, this one moves a bit too fast for me. I have to, okay, now. So these are the options of neoadjuvant systemic therapy: chemotherapy, targeted therapy, hormone therapy. These are all what we know. Hormone therapy, not many people use it, so I will actually concentrate more on the hormone therapy. And there are clinical trials ongoing for immunotherapy, Other targeted therapies such as the PARP inhibitors, CDK5/6 inhibitors, and the EGN inhibitors, which is bevacizumab. Okay. I'm really sorry, there's really something I cannot do this very well. So what about Ki-67? Ki-67 is not done in any government hospital or UMSC, but we do in private practice. Does it have a role? Well, what this paper says, is that you see, neoadjuvant chemotherapy, hormone therapy is very important for deciding on neoadjuvant hormone therapy, because if your Ki-67 is low, okay, then it will respond well to neoadjuvant hormone therapy. The less proliferative tumors, because if Ki-67 is low, it's a less proliferative tumor. The PEPI score looks at size, lymph node, ER status, and Ki-67. If it's 0, then it will be more suitable for hormonal therapy. Oncotype DX, like I say now, they want to do, if it's a low recurrence score, it will respond better to neoadjuvant hormone therapy compared to neoadjuvant chemotherapy. So basically what this tells you is you have a good, low proliferative, the very good prognosis types of tumor, ER positive, HER2 negative, you can use neoadjuvant hormone therapy to tell the downstage it. Now, what about other targeted therapies? Bevacizumab is controversial. Very small studies seems to show better response in BRCA1 or 2. PARP inhibitors, also small studies, only good in BRCA1 to 2. And immunotherapy is only phase 2 studies in triple negative breast cancer, locally advanced breast cancer, with a 60% PCR versus a 20% PCR in those that don't have immunotherapy. Okay, now types of chemotherapy regimes. This one we leave it to the oncologist, but you know the way they work from the patients that come back to you. So anthracycline and taxane combinations are the common ones. And for HER2 overexpressing, the best is actually dual block, Herceptin Perjeta combination. And generally, anti-HER2 is not used concurrent with anthracyclines because of the problem with the myocardial, cardiomyopathy. Combination with platinums in triple negative breast cancer increase response rate but increase toxicity, but they haven't shown any improved outcome. Okay, I still can't find my one about neoadjuvant hormone. Sorry, I missed this slide. This is for HER2 positive, hormone receptor positive, HER2 negative tumors. In postmenopausal women, they have done studies on aromatase inhibitors like letrozole, aromacin, and arimidex versus tamoxifen, and most studies show that AI is superior to tamoxifen in postmenopausal women. Addition of goserelin in premenopausal women, goserelin will render them postmenopausal, and you add anastrozole to it, is superior to tamoxifen. So basically, AI is better than tamoxifen, and there's no difference which of the 3 AIs you use. But the duration, you have to use at least 3 months to look at response, and if it works, then you can continue for 6 months. The response rate in well-selected patients is similar to neoadjuvant chemotherapy. Eventually, they will need surgery, but the surgery is going to be done much later. Like after chemotherapy, you are doing it after 4 months after the chemo. With tamoxifen, you might be giving tamoxifen for even 6 months before surgery. The PCR rates are a lot lower than with neoadjuvant chemotherapy, but the PCR doesn't seem to be a surrogate marker for outcome. For neoadjuvant chemo, Herceptin and Perjeta, the PCR is a surrogate for outcome, but not for the neoadjuvant hormone therapy. So this one, they say that counseling of the patient is very important because the patient has got to be patient. With neoadjuvant hormone therapy, the lump is going to be there and it's going to shrink very slowly. Whereas with neoadjuvant chemo, it shrinks usually within 1 or 2 cycles. I've gone through this. Okay, so these are all the types of neoadjuvant systemic therapy options. I just want to give some idea about what our practice is. This is a paper that I wrote when I was in SGMC, looking at 2 years. That time, 6.8% of my stage 1 to 3 patients had neoadjuvant chemo before surgery. And what I was looking at was the pathological complete response, which is usually defined as absence of invasive carcinoma, okay, or DCIS alone. Partial response is defined as reduction of more than 50% of the initial tumor size, and stable disease reduction of less than 50% of the tumor size. And this is what I found. At that time, in the 2 years when I started, we were doing it for like many stage 3 breast cancers, and the stage 2 breast cancer was only a small percentage. Okay? And you see that the stage 2 was only 5%, so majority was stage 3. And the stage 4, they will be primary chemotherapy. Okay? And in the neoadjuvant group, 1/3 of the patients who needed mastectomy were suitable for breast conserving surgery after neoadjuvant chemotherapy. Okay, so PCR rate overall, the pathologic complete response rate was 22.5%, which is quite high. But this is the usual sort of response rate we would get because these patients have both anthracyclines and taxanes. So this is a paper that was older. Okay, so the factors predicting the response rate is here. I'm not going to go much into it because this is not the topic. I'm just putting this to show you what we can do. So this is the summary. So third generation regimes give very good PCR rates. That time, because the numbers were small, we did not actually see any effect on the breast cancer subtypes. But this is something that I look at in 2018. This is from my database. And remember, 6.8% had neoadjuvant chemo. In 2018, 12.1% had neoadjuvant chemo. So we are sending more patients for neoadjuvant chemotherapy. And in Singapore, SGH, it seems that 40% of your patients actually have neoadjuvant chemo. So they will be giving neoadjuvant chemo to stage 1 patients now. For this one, the stage 2 breast cancers, 26.5%, a quarter of my patients in 2018 who were stage 2 actually had neoadjuvant chemotherapy, so much higher than the first cohort. So what I'm saying is that I'm more aggressive with neoadjuvant chemotherapy as I get older. Okay, and after neoadjuvant chemotherapy, 36.7% had breast conserving surgery, was similar to the last one. And PCR chemo alone was 23.1%, chemo plus Herceptin 75%, pathologic complete response, chemo Herceptin Perjeta 63.6%. So you have a HER2 overexpressing cancer. If you give chemo Herceptin Perjeta, you can actually get sometimes even 70%, average of 70% complete pathological response. Very expensive, but it will show that the patient will eventually have a very good outcome. So the indications for neoadjuvant systemic therapy has changed from what I said, rendering an inoperable tumor operable, to actually determine the sensitivity of the tumor to systemic therapy. And biology of the cancer is important in decision making, but we can't afford to do all this. But I will do ER, PR, HER2, and Ki-67. And some of the government hospitals do the ER, PR, HER2, and core-natal biopsy. I think HKL does it regularly, isn't it, HKL? I see some of the patients from HKL who show me their biopsy reports. Everything is there. UM, definitely, all the patients with biopsy will have ER, PR, HER2. In SMC, I will ask for it because it costs 3,000 ringgit extra to do all these markers, including FISH. The decision making should be a multidisciplinary decision. If it's possible, if you can get MDTs every week, you should discuss it with your oncologist. And of course, the patient choice is very important. Thank you very much.